Good morning, everyone. It's my pleasure to be here. First, I would like to take the opportunity to thank the organizing committee inviting me as a keynote speaker, and I'm humbled. And also, I want to let everyone know I'm here. It's not because of my achievement. It's more like what I'm going to talk about. Although, like as a VP of California North State University, and also, I also do cancer research with several patents on cancer treatments, and currently I'm editing a textbook on pharmacogenomics. But I think all this actually is not important. I think the reason the committee invited me for this keynote speech is more about what I'm going to talk about. First, I just wonder, where is everyone? There could be reason last night maybe a heavy cheesesteak, or could be, people already, on their way, try to find here, or could be here is too cold and scare people away. But you can see there are many, many reasons. So it's the same thing. However, when we talk about treatment, and how many times doctor will give you, for example, you have high blood pressure, the medication is just one dose, fix every person. So that's why my topic is about why we don't make the treatment personalized. And to me, actually, healthcare should be personal. So my topic today is about pharmacogenomics and clinical application in cancer treatment. Before we start, I would like to present a case. So here's a case of our patient, 5-year-old female patient. Lily actually got B-cell ALL, so acute lymphocytic leukemia. And, with the successful induction treatment, and after about 24 weeks of treatment, and the patient actually got remission. And then we start this maintenance therapy or consolidation therapy. You can see it's like a pretty extensive chemotherapy with methotrexate, with vincristine, dexamethasone, mercaptopurine, and methotrexate. And the plan is we're going to start this about 24-week consolidation. However, after just about 3 weeks of the treatment, and we stopped. The reason is the patient ANC, the absolute neutrophil count is 0. And a lot of time for cancer treatment, it's not cancer itself kills the patient, it's a potential complication. For example, for this patient, when you have ANC is 0, what's the risk? Infection, right? So this patient can die anytime with infection. So that's why we have to stop the treatment. But before we stop the treatment, we also figure out what happened to this patient. And you can see, of course, all this medication has potential to cause myelosuppression, but usually we never see patients, neutrophil count becomes 0. So something terribly must happen. So, of course, then they look at pharmacy, say, what's going on? Could be there's some medication error, but we checked everything. It seems like we dispensed the right medication, and then they measured the active drug concentration in patient's body. Guess what? They find out mercaptopurine, actually the concentration is 10 times higher than the regular dose. So then immediately everyone point fingers to pharmacy. You guys must dispense a drug wrong, in healthcare, what's the medication, basically what's the error margin for drug dose? It's usually no more than 5%. For oncology, some good oncology hospital, cancer center, usually it's more stringent, it's 3%. And here you have drug concentration is 10 times the normal range. So something terribly is wrong. But we checked pharmacy, everything is fine. So mercaptopurine was dispensed, based on the dose, everything is within the range. Then what's the problem? So then we checked out, we find out patient actually has a special genetic polymorphism for TPMT. And later I'm going to explain what's going on. So TPMT actually is the enzyme used to metabolize the mercaptopurine. And we find out like this patient has a homozygous deficiency of TPMT, and TPMT is used to metabolize or like inactivate mercaptopurine. So when you have the deficiency of this enzyme, what will happen? The drug is not being inactivated. So all the drugs supposed to be inactivated now stay active. So that's why you have 10 times higher of the active ingredient in your body. So you can imagine what will be the toxicity for the patient. So this is really scary. However, in real life practice, so we have clinicians here, we have scientists here, and we never really, like even FDA to tell you, okay, before you give this drug, make sure you check patient's genetic profile and make sure, this patient is suitable for this dose. It's always, okay, here's a recommendation, 50 milligram per square meter. That's all for all the patient. And when something terrible happens, oh, let's figure out, oops, what's going on, So that's exactly what happened to this patient. And the patient actually received 10 times higher of the dose. And this is really, really, like tolerated in a healthcare setting. But unfortunately, that's a reality. And even today, everywhere you go, the European countries or here in the United States, insurance, they wouldn't cover it. You don't do the genetic testing. You first try the medication, and when either the drug is not working or you have a terrible side effect, then they will figure out what happened, and then let's do the testing. So that's why in June, as a clinician, actually, we try to push, we spend so much money try to modernize our technology. So now the genetic sequence, it used take years, now it takes hours, weeks to get the sequence. And we have so much data. What's the point? In June for the AAPS National Conference for Biotechnology, they invited me as a guest speaker. We talked about this. It's just it's the wrong direction. And, we try to revolutionize the technology. We try to collect the data. But we have so much data and never really apply to patient care. So that's why translational research actually should be the focus, for the industry, for the, educational institution, and also for our federal agency. That's why, I think now a lot of leaders in the field start to realize, and that's why they, for the APS journal, they prepared a special issue, talk about pharmacogenomics, and especially ask us to present this, summarize as a clinical review, try to push, all the field people try to realize and work together and more focus on the translational study and apply to patient care. So today I will briefly overview pharmacogenomics. What is pharmacogenomics and what is the clinical relevance? And then I will give you some example about the polymorphism and some biomarkers, their impact on the cancer drug toxicity, and also talk about their potential impact, to make the treatment more specific, more personalized, and to increase the efficacy and decrease the toxicity of the treatment. And later I'm going to summarize, based on the clinical evidence, what's the FDA recommendation, and also what's the recommendation for NCCN, and which is National Comprehensive Cancer Network, and also ASCO, American Society of Clinical Oncology, for all those pharmacogenomic therapeutics. So here's some scary data, and we know cancer is scary, but we're not aware now cancer now is going to exceed cardiovascular disease, become the #1 killer in 5 years. Not only just in USA, also in Asia and in European countries. And you can see the top 5 cancer, lung cancer, prostate cancer, colorectal cancer, and pancreatic cancer for male patients. And for female patients, it's lung cancer, breast cancer, colorectal cancer, and pancreatic cancer. So in next 5 years, actually, more people will die of cancer than cardiovascular disease. This is scary. And we know we spend so much money and to treat cancer, but why still we cannot cure cancer? Here's the reason. So this is a quote. The slide is busy, but the information is very clear. It's basically the reason. This is a quote from a senior executive from GlaxoSmithKline, kind of talked about. He mentioned 90% of the drugs currently in the market, and they only work for 30 to 50% of people. And for the rest of the 70 to 50% of patients, the drug is not working. And this is from one of the top executives from GlaxoSmithKline. And kind of, I'm sure he's telling the truth, because later I'm going to show you another slide. And the reason is because, like I mentioned, our treatment strategy is one fit all, fail, trial and fail. It's just no wonder some drug doesn't work. It's just we all have personal experience, and we got headache, and certain people recommend, oh, this drug worked for me magically, but when you try it, it doesn't work. And sometimes doctor give you a dose, for certain testing, and people with different ethnicity background, people with different, body index, the same drug with the same concentration, and when it get into your body, the effect will be totally different. So that's why it's not a surprise. And this slide, actually, when I showed, many people just cannot believe it. This slide basically shows, all the drugs we have right now. You can see for the major categories, oncology, Alzheimer's disease, and hepatitis, osteoporosis, asthma. So all these drugs in the market right now, you can see the effective rate is almost above 40%, particularly for cancer treatment. 75% of the drug, they're not really working for the patients. Can you believe it? And what's the reason? That's because, the drug is just, when they do the clinical trial, it's only work for certain small population. And then FDA approved it, and now they try for every patient. So that's why, we need to do, get more clinical evidence, especially, how we know we're different. Start with the gene. You get the genetic profile, and you figure out, when we talk about targeted therapy, do you have the, the target for the specific marker? If you don't, then this drug doesn't work for you. And when you give the treatment, you have severe toxicity, like that patient Lily, with mercaptopurine. And if you have the TPMT deficiency, so that means you cannot metabolize this drug, and then you need to decrease the dose. So you give the same drug, and even though the drug is working for you, you cannot tolerate. Why? Because the toxicity is going to kill you. You have the 10 times the normal drug concentration, and especially we're talking about chemotherapy. Chemo drugs, they have a narrow therapeutic index. When you have 10 times, absolutely, this patient will die of, all this infection, with absolute neutrophil count 0. That's just, unbelievable. And all the other treatment is similar. It's just right now, I feel like in healthcare industry, a lot of concentration is more about the cost effectiveness, but never really is about, you look at the short term, maybe it's true, the genetic testing, is pretty expensive. However, you look at the long term, first, people's life is priceless. Second is you saved all the trips to emergency room. You saved all the trips for the further treatment for the complications of the toxicity. And third, basically you find out the effective drug from very beginning. So to me, I feel like definitely everything is worthwhile, and we should go to this approach for pharmacogenomics. So currently, the approach is basically trial and error, or trial and fail. So here's the treatment. Okay, you're lucky, and you are the lucky 30% to 50% patients. The drug is working for you. That's great. But some patient, the drug is not working, then physician will say, oops, you know, the dose may be too low. Let's increase the dose and try again. And some patient, like that small girl, 5-year-old Lily, the drug actually cannot tolerate. Patient got severe toxicity, and then doctor will say, oops, what's going on? Maybe the dose is too high, and then they will decrease the dose. But for that patient, chemotherapy, like I said, it's narrow therapeutic. Can you imagine they will decrease the dose from for example, 50 milligram to 5 milligram for chemotherapy? No way. And usually it's like within about, no more than 5% change, unless patient has a renal deficiency or hepatic problem. So, but that's the case like for most of the treatment, and when you have the toxicity, doctor will decrease the dose and try again. If you still cannot tolerate, then decrease further, or when you decrease the dose, drug is not working. So if you have the, like for example, hypertension, you can, have this time to try and, to change. But when you have cancer, and do you have time to wait? Do you have the time to, experience this kind of trial? So that's why pharmacogenomics has the best application for oncology, for cancer treatment. Here I list out all the hallmark features for chemotherapy, and you can see basically, first, many of the cancers, they're rapidly and inevitably fatal for, with a very, very narrow therapeutic window. For example, the pancreatic cancer or melanoma, you only have no more than 6 months. If you don't start the treatment, patient can die within 3 to 6 months, definitely. And particularly, we also lack of the markers for early detection. And the lung cancer and the pancreatic cancer, most of the time, when you finish the diagnosis, patient already at stage 3 to stage 4. So, and if you wait for the treatment and try different medication, what's the consequence? And particularly chemotherapy, they are very, very toxic. So that's why they have very narrow therapeutic index. If the dose is too high, then you have severe toxicity. If the dose is too low, it's not working because these are tumor cells. And if you decrease the dose a little bit, it's not working for patient. And also the overall response rate and all these chemo drugs, they all have severe toxicity. And also the potential resistance because tumor cells, they're constantly mutating. So, all this risk put together, so it just don't give you any space to do this traditional trial and fail. We have no chance to fail. We have to figure out what's the best solution for our patients. So why all the treatment is different for our patients? And you can see, because you, me, every audience here, we're all different. So the treatment, actually, you can see our morphometric, like the body size, the body composition is different. That's why, now FDA, they realize this, so all the dose treatment, all the clinical trial, pediatric patient and adult patient is different. Because for pediatric patient, their body composition is totally different. For example, their percentage of the water is definitely higher than normal adult. For example, gentamicin, usually we assume for the pediatric dose, it should be lower compared to adult patient. For example, gentamicin, actually, for pediatric patient, actually the weight-based treatment is the dose is much higher than adult patient because their composition is different. And also another reason is because of age and our ethnicity and our gender. So our metabolism rate is different, and particularly male patient and female patient, certain disease, actually the treatment is totally different. And the age, I just gave you example, for breast cancer. The treatment strategy for patient before menopause and beyond or after menopause is totally different. For patient with breast cancer, before menopause, we know where the estrogen from, right? It's from ovaries, and is from the ovaries. So that's why, the treatment is more like we can give the tamoxifen for the treatment. But after the menopause, the estrogen is not really from the ovary, it's more from the adrenal. And that's why the treatment is different. Instead of use tamoxifen, then we use aromatase inhibitor and stop the conversion of the estrogen, from the adrenal gland. So later we're going to talk about this. And how about pharmacogenomics? Pharmacogenomics actually cover every perspective of the treatment, from the drug target, so basically tell you, whether this treatment target is selective, whether patient has a biomarker for the treatment, to like metabolism, talk about the PK/PD, so if you have the pro-metabolism enzyme, so then, the dose will be justified. And if you have the certain drug transporters, then you kind of experience the resistance because you give a heavy dose, the drug will be effluxed outside, so the drug is not working. And then, of course, we also need to look at all this pharmacological difference. The drug-food interaction will all have different dietary habit. So certain patient, for example, patient on warfarin, and when you take a lot of green, like food, like basically the risk for the bleeding, obviously, is different from people. It's more like my son is a meat eater, so it's totally different. And also the drug-drug interaction and the different dosage form. So eventually, we also have to pay attention about the drug disease, like patient's renal function, hepatic function, and whether this patient is pregnant. So when you take all this into consideration, and you can say, give me a reason why our treatment should be the same. There's no reason our treatment should be the same, right? You look at everything here, we're all different. And why my doctor is giving me the same treatment. For example, here's a patient with obese and a patient basically with renal failure, and then come to your clinic for like a hypertension, compared to me, like a relatively healthy and just come to this presentation maybe a little bit panic and with a high blood pressure. So you go to your doctor, the treatment will be different. For me, as doctor just say, okay, just calm down, maybe have a drink, relax, you will be fine. But for that patient, you have to treat the renal failure first, before you fix the high blood pressure. So that's why pharmacogenomics actually is a solution for the personalized treatment. And you can say pharmacogenomics, we will identify the polymorphisms for the genes, for the drug metabolism, for the drug transporter, for the drug target, the receptors, and also talk about all the potential pathway involved in the adverse reactions, and to help you to identify who will respond to the treatment, who is not going to respond. So throughout all the treatment category, you can see it will help you to do the early detection of the treatment. Like we mentioned, pharmacogenomics actually will help you to identify the potential biomarkers for early detection of cancers, and also help you to identify the drug markers, the drug targets, and then help you to do the PK and the PD to identify what's the risk, for the pharmacokinetic, metabolism difference, and also talk about the drug efficacy and the toxicity associated with the treatment. So eventually with pharmacogenomics, and then we will first identify which group of patients will respond to the treatment and which group patients will not respond to the treatment. For patients who will not respond to the treatment, so we will identify what's the reason, and maybe they don't have the target, or maybe they cannot tolerate the drug because of the toxicity. So then we based on this evidence, we kind of like form a personalized treatment regimen. So if patient cannot tolerate because of the toxicity, then we will identify, so, which enzyme. Are you a homozygous or heterogeneous, deficiency? Then we adjust the dose. The dose justification strategy will be different. So if you don't have the specific biomarker, of course, this drug is not for you. So then we change it to different drug. Instead of we let you try, also about the cost of chemotherapy. And like the cancer treatment, some of the monoclonal antibody, just one dose is about $10,000. So do you want to try it? Yeah. Also, right now, pharmacogenomics, at the beginning, people kind of confused with the pharmacogenetics. Pharmacogenetics before is more like at a single gene level, but now pharmacogenomics is integrated to the genome-wide approach. So basically, we not only look at the polymorphism for the single gene, we also look at basically the pathway of their signal transduction, and also about the metabolism, and also at the mRNA level, at the protein level. So it's an integrated approach, so to kind of provide you the evidence, what's the best treatment strategy for the patient, and to predict what will happen to the drug treatment efficacy and to the toxicity of this patient. So once we have the evidence, so we can recommend a treatment regimen to maximize the treatment efficacy and to minimize the toxicity associated with the cancer treatment. So that's what I'm called, evidence-based individualized medicine, which is pharmacogenomics. So what's the potential clinical relevance for pharmacogenomics? And you can see it's at every level. So basically, when you have the genetic polymorphism, and there are so many, there are like millions of polymorphism associated with every genes. However, not all the polymorphism will have some impact. So basically, that's why kind of at the beginning I mentioned, during the FDA panel, I made a recommendation. So they collected tons of the data about the polymorphism, and when I asked them, what's the clinical relevance? And they have like several officers from FDA drug development panel, and they just have no clue, because all the data right now is basically, it's just pure data there, and it's not really linked to a specific group of patients. It's not linked to basically the potential, a treatment recommendation. It's just for the sake of collecting data, they're collecting data, yeah. So for us, actually, we would recommend when you have the polymorphism, and we will say, okay, what's the consequence? Well, it affects the PK, or well, it affects the PD, or eventually it will affect the treatment efficacy and the toxicity. Because only when you have this evidence, you can apply it to the patient care. Otherwise, all this data is just occupied the storage space, and it could cause too much trouble, because now the data is getting too big, and it's just sometimes it's too big for you to do anything, because then the approach from very beginning is wrong. So now you have a humongous database, and it just people don't know where to start and what's the best approach. So right now for pharmacogenomics, actually there are pretty much three major categories applied to patient care. I would say there was one more about the drug resistance. So the major application is more about application of pharmacogenomics in, to prevent the toxicity. So I give you some example about the UGT1A1. It's involved in irinotecan and DPT for 5-FU, TPMT for mercaptopurine, and G6PD is involved in some supportive care like a respirase for tumor lysis syndrome. And we also can apply pharmacogenomics to help us to identify the biomarkers for the treatment. For example, all the EGFR blocking monoclonal antibody, the HER2, well-known Herceptin. So you have to identify whether the patient is HER2 positive before you give the treatment. And of course, you have this KRAS mutation for people with EGFR, like the epithelial cancer, such as colorectal cancer, lung cancer. You know, we usually start the treatment with the EGFR blocking antibody or the tyrosine kinase inhibitor specific for the EGFR signal transduction pathway. But when you have the KRAS mutation, this drug is not working. So that's why KRAS, you know, like pharmacogenomics is very critical, because if you don't identify this potential mutation, you give this treatment, not only is not working, you are wasting the money, the time, and also it causes severe toxicity. So BCR-ABL for, you know, like a CML treatment, you know, all this actually, even though pharmacogenomics, every time when we talk about, people think, oh, that's for future. So even like there's a journal called Future Medicine. So all they talk about is pharmacogenomics. In real life, for cardiovascular, you know, for psychiatric, pharmacogenomics actually is not really in practice. But in oncology, it's on daily basis. We're using pharmacogenomics to treat our patients. Because as I explained, you know, we cannot really tolerate any of these consequences. You know, like as a neurotherapeutic drug, you have 10 times of the active ingredient in your body. That's just unbelievable. So we have to use pharmacogenomics to guide us for cancer treatment. And pharmacogenomics, of course, can also be used to identify the biomarkers for early detection of the cancer. For example, PSA, you know, for prostate cancer, BRCA1 and BRCA2, you know, for the breast cancer, ovarian cancer, and the KRAS mutation kind of help you to identify the prognosis outcome for our patients, you know, for epithelial cancers such as lung cancer and colorectal cancers. And at the beginning, I kind of mentioned the pharmacogenomics also can identify which group of patients have higher risk of drug resistance because of all these efflux, you know, pumps. So now I just switch the gear a little bit to give you the real evidence and example about the application of pharmacogenomics in cancer treatment. Okay. So I'm going to take a little bit of extra time for Dr. Chang, you know, like we combine some of the topic, and for me just to provide more clinical evidence, and then Dr. Chang will talk about what's a challenge for industry and also for the educational institution. Yeah, thank you for reminding me the time. Yeah, if I talk too much, let me know. I have too many slides, yeah, but again, like I explained, it's just this topic is kind of critical. We have a lot of evidence and, you know, recommendations to share to the industry and to the clinicians. So irinotecan and UGT1A1. So what's irinotecan? This is the most commonly used chemotherapy and for a lot of common cancers like cervical cancer, you know, esophageal cancer, and it's basically for GI cancer, lung cancer, pancreatic cancer. And this treatment, this drug actually is very toxic. The active metabolite is called SN38, and basically this drug is working by inhibiting topo-1 isomerase. And basically also the black box warning is very severe. It can cause life-threatening diarrhea and myelosuppression. And this drug, you know, I'm going to skip like other metabolism. I only talk about UGT1A1. So the active ingredient is SN38. And this one actually later will be activated by the UGT1A1 and become SN38G. So when you have the deficiency of the UGT1A1, you can see the drug will stay active in your body. That's why if you don't do the pharmacogenetic testing and a patient has UGT1A1 deficiency, so they have a higher risk of diarrhea and myelosuppression. And the diarrhea, I can literally tell you, patient just living in the bathroom, cannot get up. So it's that severe. So that's why I can tell you UGT1A1 testing now is kind of a common practice. However, right now, a lot of insurance, they wouldn't cover it. They will let you try this drug first to the patient. If patient develops the diarrhea, let's do the genetic testing, see whether you have this UGT1A1 polymorphism. If you do, and then let's decrease the dose. So it's scary, but that's a reality. So that's why, although it's in practice, it's not in the perfect condition. So we're still pushing the pharmaceutical company and the FDA and also the insurance industry, to be more proactive. So here's some clinical evidence, and I don't think we have a lot of clinicians here, so I'm going to skip it. So basically, the clinical evidence kind of will tell you what are the polymorphisms and also what's a correlation of the polymorphism with the different ethnicity for us to identify the potential risk factors. But I just want to tell you the correlation here. And you can see based on the clinical trial, it shows for patients with UGT1A1 polymorphism, they have 7 times more risk to encounter the toxicity. And also for patients with this kind of polymorphism, and they have a higher risk of this life-threatening toxicity for diarrhea associated with irinotecan. And this is just more clinical evidence to show you, basically the drug concentration for the active ingredient actually is almost 5 to 7 times higher. So again, we're talking about the error margin for chemotherapy is 5%, and here we're talking about 500 times. That's scary. So even with all this evidence, right now FDA's recommendation is still, okay, if you use a combination regimen for FARI, for colorectal cancer, the dose is less than 150, still do the trial and fail. If the patient develops the toxicity, neutropenia, or the severe diarrhea, and then they do the testing. It's only recommended for patients with a higher dose for the monotherapy of irinotecan. You do the testing, and then they recommend based on if it's a homozygous, then they recommend to decrease the dose. If it's a heterozygous, they even just say don't bother. But we know the potential impact is pretty significant. So this is the FDA's recommendation. It's not really dose specific, so there are more work need to do. So this is another drug recently approved by FDA. I don't spend too much time about it, but it's similar, UGT1A1 is involved in the drug metabolism, and so again, with the clinical evidence, FDA recommended just to reduce the dose. And this one, because it's recently approved, so their FDA requires the company to do a specific clinical trial to show the correlation of the genetic polymorphism and the dose reduction. So this one, they have a specific dose recommendation. And the nilotinib is another drug approved for CML, and also it's an inhibitor of UGT1A1. So this one is another level about a therapeutic recommendation. When you consult patient, you not only just know about the polymorphism, you also need to know this drug is an inhibitor of UGT1A1. When you combine these two situations, the consequence will be more severe. So mercaptopurine is another case we mentioned at the beginning. So this one actually, I just kind of briefly mentioned, mercaptopurine is another major chemotherapy. Actually, this drug is metabolized by TPMT, and the severe toxicity is myelosuppression and tumor lysis syndrome. So even though it's a smaller population with this polymorphism, but you can see the impact is huge. The drug concentration could be 10 times higher compared to the wild type genetic genotype. So with this polymorphism, and the consequence is like basically if you are the pro-metabolizer of TPMT, your active drug can be 10 times higher compared to the normal patient. And as I said, it's a smaller group of patients, but the impact actually is huge. It's only about 0.2% of the patients with this polymorphism, but it counted about 1/3 of the patients with grade 4 or grade 3 toxicity associated with mercaptopurine therapy. So this is the FDA's recommendation. Again, no specific dose recommendation. They just recommend, okay, if you have this polymorphism, then you should talk to the doctor and maybe you should adjust the dose. But exactly how to adjust the dose, nobody talk about. And NCCN is basically evidence-based clinical guideline recommendation. They give you the specific guideline. So for a patient with heterozygous, so they recommend 10 to 15 times of the deduction. But for patient with homozygous, they recommend 10 times to 15 times of the dose reduction. That's really unbelievable. I can tell you, without pharmacogenomic evidence, nobody dare even think about 2 times reduction. Right, Dr. Chan? You are expert of oncology, so. All right, so next level, I'm going to talk about the selective treatment. So this one, I just kind of briefly summary, like for breast cancer, we have the estrogen receptor, we have the HER2, and the colorectal cancer, we have the EGFR receptor KRAS mutation, and we have the GI stromal tumors. So basically the c-KIT is the biomarker, and for the liquid tumor, like leukemia, so basically we have the Philadelphia chromosome, the BCR-ABL, and also the PML-RAR, for arsenic trioxide treatment. Lung cancer is the EGFR, KRAS, and ALK. So melanoma is the BRAF. So I have all the recommendations for the specific treatment, but here I just listed all these drugs, kind of tell you it's already in everyday practice. So it's not just talking about future treatment, and right now you can see every drug of this, for example, if you don't have the EGFR, you don't have the estrogen receptor, so we cannot give you the hormonal therapy. And if you don't have the HER2, and basically all these categories, the Herceptin, pertuzumab, and the Kadcyla and the lapatinib, basically you cannot start this treatment. You must be HER2 positive. For colorectal cancer, it's the same thing. You must have the overexpression of the EGFR receptor. You can give this blocking antibody for the EGFR to get the treatment. Otherwise, if patient has a KRAS mutation, like basically it's a downstream signal transduction, the signal transduction will be constantly active. So even you block the receptor level, doesn't matter, still the cell will continue proliferate and the treatment is not effective. So that's why we're going to give this different treatment. So I just give you a little bit more details. So ALK is basically the new biomarker for lung cancer treatment, and I show you some of the evidence here. Why the pharmacogenomics is not just at a single gene level, it's like a genome approach. This is like, for example, for patient with colorectal cancer, we know it's epithelial cancer, so they have the overexpression of the EGFR. So then we have the blocking antibodies to block it, so that's the first-line treatment. But when patient got the KRAS mutation, as I explained, is a downstream signal transduction, then the cell is constantly active, like the proliferation is based on the KRAS mutation. It's not because of the overexpression of the EGFR. Even you give the patient the cetuximab to block the EGFR, you're wasting the money, you cause the toxicity, but you're not treating the patient. So that's why for KRAS mutation at this point, the treatment is still the traditional chemotherapy, even though we're developing the downstream signal transduction, but all the treatment recommendation is evidence-based. So far the clinical trial is ongoing. So here is just to show you all the clinical evidence with the clinical trial data here. But I can tell you, if you don't follow the recommendation of the pharmacogenomics, and the consequence is severe. This is basically some clinical evidence for non-small cell lung cancer with gefitinib. When you have this EGFR mutation, the gefitinib actually works better than the traditional chemotherapy, the paclitaxel and the carboplatin treatment. So, but if patients, they don't have this mutation, when you give the gefitinib, actually cause more harm. So that kind of tell you pharmacogenomics actually is critical for the treatment. And here's the evidence. So, you don't have to understand what's the EML4 ALK fusion gene, but this is the gene involved in the cell proliferation. But I show you basically here. This is a perfect example about the role of pharmacogenomics in drug development. And this gene, originally, fusion gene was discovered in 2007. And then basically 2008, the first evidence showing like basically with this kind of ALK inhibitor, it can inhibit the lung cancer cell line proliferation. So that's no big deal. And then 2019, they developed the the first phase 1 clinical trial. And in 2011, the drug is approved. That's within 4 years. And we know traditionally a drug from the drug target to a drug approved by FDA will take at least 10 years. So this is a very successful story and a very encouraging story about pharmacogenomics. With the pharmacogenomics guidance, the drug actually is approved, like very, very quickly from the identification of the gene to the approval of the drug. Took only 4 years. That's amazing. So the clinical recommendation, of course, you have to have this fusion gene expression before your treatment. And now, because of pharmacogenomic evidence, this kind of treatment becomes the first line. But of course, you need to do the genetic testing first in order to start erlotinib for people with EGFR mutation and also crizotinib for patients with ALK positive. And then FDA, they have all this recommendation specific for the treatment. But I can tell you, even though with all the specific genetic polymorphism, again, we're talking about tumor cells, they always try to figure out a way to go around it. And there is always a specific mutation, the drug is not working. So we know here, before I finish to the conclusion, I want to give you one more example about the treatment for melanoma. And melanoma, actually, the advanced stage is almost a death sentence. If you are diagnosed like stage 4 melanoma, actually within about 6 weeks, patient can die. It's very, very malignant, and there's no treatment. It is resistant to all the traditional chemotherapy, and even the new target therapy is not working. That's why recently they have this new drug targeted specifically as a BRAF mutation, because this mutation is very popular in melanoma patients. And then, patient can extend their lifetime for almost some patients to even up to 9 months. So that's very, very significant. So that's why FDA, they recommended for those patients, you first do the pharmacogenetic testing, see the BRAF mutation. If you have the mutation, and this drug, vemurafenib, is a first-line treatment. So now they develop some other drugs. It's also targeting at the BRAF mutation, but also focus on the downstream signal transduction. I don't know what button I touched, but I guess maybe someone controlled it to tell me it's time to finish, right? So my recommendation is basically pharmacogenomics actually is a key for oncology practice. And we not only need pharmacogenomics for us to identify the toxicity, also it's very essential for us to basically to identify, whether we have the specific biomarkers, to select the treatment. And of course, pharmacogenomics will also help us to identify the biomarkers to do the early diagnosis and also to predict the potential, prognosis for the treatment. eventually pharmacogenomics also will help us to prevent the potential resistance of cancer treatment. Thank you. Any questions? The cost actually, it used to be like about $1,000, but now some of the genetic testing is much cheaper. I think there's like in Walgreens, they're selling the kit, like you can find out like about 100 genes, the common metabolism, like CYP, like about the TPMT. It costs about, last time I know they gave a discount, it's about $350. Yeah, so right now, a lot of this genetic testing is PCR-based. If you do the histology, staining, and the fish staining, it's pretty expensive. But now with PCR, it's very simple. Yeah, so with the PCR genetic testing kit, it's about within hundreds. Yeah, so you can do it. So that's why it's getting more popular.